Welcome to the channel. I'm Work in Progress, and you're watching the DSM-5 Explained. In my last video, I went over several treatment modalities, including play therapy, art therapy, and animal-assisted therapy, as well as their histories, the topography of what each modality might look like, and the domain of effect. In this video, I'm going to be continuing that trend and talking about EMDR, trauma-focused cognitive behavioral therapy. And as this is a part 2, I plan on jumping right in. Please check out my part 1 video if you have any questions. As always, before we go any further, the video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. With that out of the way, let's begin. Eye movement desensitization and reprocessing, or EMDR, is a new and revolutionary modality in the non-invasive treatment of traumatic experiences. In 1987, its founder, Francine Shapiro, was walking in a park one day and came to the realization that her own eye movements correlated to a decrease in emotional distress. Upon further investigation, it became apparent that eye movements by themselves didn't create a long-lasting, comprehensive therapeutic experience. After this, she began incorporating additional facets, including a cognitive model. Subsequent to much experimentation, the resulting standardized procedure was dubbed eye movement desensitization, or EMD. Shapiro then put her new procedure to the test, conducting both a case study and a controlled study with tremendous success. The controlled study consisted of 22 traumatized individuals, half of whom would receive EMD, and the other half who would receive the same treatment with imagery and detailed description replacing the eye movements. The participants who had undergone EMD reported significant decreases in ratings of subjective distress and significant increases in ratings of confidence in a positive belief. Participants in the EMD condition reported significantly larger changes than those in the imagery condition. A single session of the procedure was sufficient to desensitize subjects' traumatic memories, as well as dramatically alter their cognitive assessments. Because EMDR therapy was an effective treatment achieving results very quickly for many clients, Shapiro felt an ethical obligation to teach other clinicians so that individuals suffering from PTSD could find relief. Despite its demonstrated effectiveness, similar to most new approaches in psychotherapy, EMDR has been surrounded by controversy. While some critics have labeled EMDR a pseudoscience, others have commented that these conclusions are based on a misinterpretation of the literature. One of the most exciting aspects of EMDR is its versatility, with patients reporting success in recovering from anxiety disorders, including generalized anxiety disorder, panic disorders, phobias, and social anxieties and phobias, depression disorders, including major depressive disorder, persistent depressive disorder, and illness-related depressions, dissociative disorders, dissociative identity disorder, and amnesia, or depersonalization and derealization disorders, eating disorders, including anorexia nervosa, bulimia nervosa, and binge eating disorder, gender dysphoria, obsessive-compulsive disorder, body dysmorphic disorder, and hoarding disorder, and personality disorders, including borderline personality disorder, avoidant personality disorder, and antisocial personality disorder, as well as trauma disorders, including acute stress disorder, PTSD, and adjustment disorders. Now, on the other side of the coin, EMDR has the faults of its virtues. Since it is so versatile, it may lead some to consider that there is a third-party variable at work, and it is simply the hype surrounding EMDR which is leading to such profound results. Regardless of what side of the aisle you fall, EMDR still remains a lifeline for some who have not had the success that they wish with other modalities. The topography of EMDR is pretty straightforward. A patient history is obtained and any relevant information is gathered. After this step, The patient and their history are assessed and make sure there aren't any potential confounding factors. The patient is then guided through the EMDR session by a trained professional. The professional will ask the patient to do a body scan to find any areas that come into focus when they think on their traumatic experiences. While in this state, the experiences are, as the name suggests, reprocessed and the patient desensitized to them. When the session is over, the therapist will guide them through a script meant to ensure closure and stabilization. The patient and therapist together then reassess the patient's needs and plan their next steps together. Trauma-focused cognitive behavioral therapy, or TF-CBT, was developed by Dr. Anthony Marinano, a longtime leader, clinician, and researcher at AHN, Judith Cohen, a child and adolescent psychiatrist, a professor of psychiatry at Rowan University, School of Osteopathic Medicine in Stamford, New Jersey, where she's also the co-founder and co-director of CARES, Child Abuse Research, Education, and Services. Currently, 14 randomized controlled trials have been conducted in the United States, Europe, and Africa, comparing TF-CBT to other active treatment conditions. All of these studies have documented that TF-CBT was superior for improving children's trauma symptoms and responses. The primary goal of TF-CBT is to reduce PTSD symptoms amongst children and adolescents. TF-CBT provides structure for the use of cognitive behavioral principles in the context of two paramount developmental considerations: the role of the caregiver and the developing nature of the child's emotional regulation and coping abilities. The model originally was designed to address PTSD symptoms associated with sexual abuse, depressive symptoms, behavioral problems including aggression and inappropriate sexual behaviors, and unhelpful thoughts and feelings regarding the abuse, such as cognitive distortions, guilt, and shame. Subsequently, the model has been adapted to treat various types of abuse and other traumas, such as experiencing physical or emotional abuse or neglect, and witnessing community or domestic violence, traumatic loss, war, or natural disasters. TF-CBT was designed to be delivered in 12 to 16 sessions of outpatient treatment, depending on the needs and ability of the child and caregivers. Trauma-focused cognitive behavioral therapy targets feelings and issues such as guilt, shame, powerlessness, depression, anxiety, behavioral outbursts, as well as PTSD symptoms including sleeplessness, agitation, flashbacks, nightmares, anger, poor concentration, hypervigilance, emotional numbness, and low self-worth, as well as somatic responses like bedwetting, stomach aches, headaches, night terrors, tantrums, and self-harm. In addition, it can also help with things like substance abuse, as well as calming the responses associated with traumatic triggers. TF-CBT helps children address distorted or upsetting beliefs and attributions and learn skills to help them cope with ordinary life stressors. It also helps parents who are not abusive to cope effectively with their own emotional distress and develop skills to support their children. Practical components of TF-CBT include psychoeducation about child trauma and trauma reminders, parenting components including teaching parenting skills, relaxation skills individualized to youth and parents, affective modulation skills tailored to child, parents, and culture, cognitive coping, connecting thoughts, feelings, and behaviors, trauma narrative and processing, in vivo mastery of trauma reminders, conjoint parent-child sessions, enhancing safety and future developmental trajectories, and processing traumatic grief. And with that brings us to the end of our video. If you found anything in here enjoyable or informative, please drop a like and share with your friends. Hey y'all, I named this channel What I Did for good reason. I wanted a constant reminder that as accomplished as any one may feel, we are all just works in progress. I am no different than anyone else in this sense, and I need your help to grow and learn. I put my heart into each of these videos and have a great time doing it. However, in order to make these videos the best they can be for you, the viewing audience, I am asking for your feedback. What you like, I'll keep, and what isn't as well received, I'll do my best to correct. We are in this together, and if your comments are particularly poignant, I may even feature them at the end of a video. Wherever you are on your journey, just remember, each and every one of us are simply works in progress. See you next time.